Good evening, everyone. Welcome to Renal Medicine. We'll start our renal medicine lecture with a remarkable story. In 1950, there were two brothers named Ronald and Richard Herrick. Ronald and Richard wanted to prove the world that they were non identical twins. However, even after performing 17 genetic tests and taking fingerprints in front of the journalist, they were unable to prove that they were not identical. It was only after a reciprocal skin grafting that they were able to demonstrate they were non genetically identical twins because the skin grafting has completely healed without using any immunosuppressant medication. After a few days later, Richard became ill with disorientation. At this time, the psychiatrist diagnosed him with uremic encephalopathy. Not only Richard had disorientation, but he was also diagnosed to have hypertension, pedal edema, severe electrolyte disturbances, and arrhythmias. It was at this moment that the physicians considered renal transplantation from Ronald to Richard. And Ronald agreed to donate one of his kidneys to Richard, making him the world's first living organ donor. Then the surgery was performed by Dr. Joseph Murray on December 23rd, 1954. The surgery went well. It was a success, and Richard's new kidney functioned well, and he went on to live for 8 more years. And during the hospital stay, Richard met a nurse, and eventually he married that woman in USA. Ronald, who donated the kidney, lived for a long time, and he died at the age of 79, and he passed in 2010. Joseph Murray received a Nobel Prize for performing the first living organ transplantation. This story proved that kidney transplantation could work and paved the path for future developments in renal transplantation and also immunosuppressive therapy. This story remains one of the selfless love and medical progress in medicine. Why did I start with this story? When you see this story, you can understand that the presentation of the kidney disease can vary, involving the nervous system, heart, legs, skin, appetite, and everything. That is how the kidney disease presents. It is mostly with the nausea that the patient comes because kidneys are the most important organs which excrete the waste material. Whenever the waste is not excreted from the body, the patient develops nausea. So nausea is the first most important symptom the patient complains of kidney disease. When you also consider the further presentation of kidney disease, you will understand that most of the patients will be asymptomatic. It is only through the lab test that we can diagnose a kidney problem. For example, when patient presents with non-visible hematuria or microscopic hematuria that is detected only on a urine dip, you'll have to consider that it is mostly not because of the renal problems the patient can present with non-visible hematuria, but it is most of the time the urological problems that needs to be considered in patients age more than 40. This is what you'll find in USMLE questions. So, patients age more than 40, please do a urological investigation as the first step. There is also another presentation where patients are asymptomatic. It is asymptomatic proteinuria. Normally, the kidney excretes less than 150 milligrams of protein every 24 hours. And this 150 milligrams, less than 150 milligrams for 24 hours of protein is excreted in non-pregnant women. Remember that. However, if you want to measure how much protein is lost, the most accurate thing you can do is albumin creatinine ratio. So, whenever in the question the examiner asks, what is the confirmatory test to detect proteinuria? It is the albumin creatinine ratio. Sometimes the patient will be asymptomatic. The patient will not have any nausea as well. It is only by the it is only by testing the renal function test we usually identify that the patient has got increased creatinine ratio. That is when we consider that the patient has got abnormal kidney functions. Next, we talk about one of the most important presentation of kidney diseases, that is patient presenting with hypertension. Whenever the patient presents with hypertension, you'll also have to understand that you not only have to diagnose hypertension, but it is most important that the patient have to be ruled out from proteinuria, hematuria, and also test for renal functions. That is what the examiner will be interested in. The next most investigation you will have to do after diagnosing the patient with high blood pressure is check his EGFR, check his proteinuria. Sometimes patient can present with arrhythmias because of the raised potassium, hyperkalemia. Why do patients present with hyperkalemia? It is only through the renal system that potassium is excreted. Whenever the potassium is elevated, the heart is affected. The acid base disturbances are affected. The patient can present with arrhythmia when the patient has got hyperkalemia. Remember, whenever I think of hyperkalemia, it is the heart that is affected. But whenever I think of hypernatremia, it is the brain that is affected. So, in patients with hypernatremia, patient usually present with seizures. In patient with hyperkalemia, patient usually presents with arrhythmia. Very important. And what needs to be avoided in patient with hyperkalemia? It is the coconut water. It is the glycine substances that we need to avoid. It is the glucose that we need to avoid. In USMLE Step 2, glucose is commonly tested. What is the most important food product that we need to avoid? Glucose needs to be avoided, because in the question the examiner mentions that the patient has been eating lot of glucose. What happens? The hyperkalemia kicks in, the arrhythmia sets in. So glucose is one of the most important substances you'll have to avoid. So lifestyle changes needs to be considered whenever you find glucose in the question. Talking about the symptoms of the kidney and urinary tract, I want you to understand that the urinary tract symptom, the most common symptom tested is dysuria. Why do I say dysuria? Dys is pain. So it is a discomfort with micturition. Sometimes dysuria is also associated with other symptoms of urinary tract. What are the other symptoms of urinary tract? It is the urgency, frequency, and nocturnal urination, also called as nocturia. Remember, whenever you find dysuria, whenever you find urgency, frequency, nocturia in the questions, it is the urinary tract symptom. It is not the renal symptom. Remember this, please. You will have to think of urinary tract infection or cystitis when you have urinary symptom. It is only with the suprapubic pain that we diagnose cystitis. If there is no suprapubic pain, it is only the urinary tract symptom that we will have to think of. Examiner is very fancy in framing a question saying that this patient has got dysuria. What is the most common source of infection? It is the urinary tract infection that we will have to diagnose. Dysuria with suprapubic pain, it is the cystitis that you will have to think. Dysuria without suprapubic pain, but the patient has got loin pain. My first most important differential diagnosis is pyelonephritis. Remember, pyelonephritis is diagnosed clinically. Pyelonephritis is diagnosed on clinical examination. So I want you to understand that there is no confirmatory test for pyelonephritis except for the clinical examination. That is why examiner will not give you any of the ultrasound findings or the CT findings in patient with pyelonephritis. It is the clinical diagnosis with dysuria and loin pain. You will have to consider pyelonephritis. However, there are other causes of loin pain. Loin pain without dysuria. Think of kidney stones. Loin pain without dysuria. Think of infarction of the kidneys. Loin pain initially, and then the pain has been changed and is now severe and is radiating to the testis in males. Think of ureteric colic or think of ureteric calculi. Most important question commonly tested in USMLE. Remember, ureteric calculi can also be seen in papillary necrosis because most of the papilla are sloughed off in papillary necrosis and they can form a debris. So, ureteric colic must be considered in patients with papillary necrosis and is one of the complications of papillary necrosis you will have to understand. It is about understanding the symptoms, the presentation, the clinical examination findings. That is when you can diagnose the renal problems. Most of the renal problems does require biopsy for confirmation, but the patients who come to the outpatient and the patient who comes to the emergency needs to be diagnosed clinically. Next, I want to talk about another symptom where the patient is frightened. The most common out of hospital scenario is eating a beetroot. Whenever the patient eats beetroot, the patient will have discoloration of the urine. Think of beetroot ingestion. Include the history, include your questions in the history. Ask the patient what kind of food has he taken. First, most important thing. Patient with rifampicin has got a discoloration of urine, which is orange red urine. Ask about the medications if there is discoloration of the urine because rifampicin causes orange red urine without any symptoms. So, what is the next best step after starting or before starting rifampicin? Educating the patient, telling the patient that this patient will have an orange urine discoloration. That's the most important thing. Sometimes patient presents with visible hematuria, that is also called as gross hematuria. Whenever gross hematuria is seen, whenever painless hematuria is seen, the first most important option I want you to select is a urinary cancer in elderly patient who has got a history of smoking, who has got a history of aniline dye exposure. Please think of transitional urinary bladder cancer whenever there is visible hematuria. If there is no transitional cell cancer in the options, it is the malignancy that you will find. So I want you to understand that visible hematuria in USMLE points out towards the diagnosis of malignancy in elderly patient. In young patient, whenever there is visible hematuria, I want you to understand that this patient or the examiner is testing polycystic kidney disease or the examiner is testing glomerular disease. I also want you to understand that patients with visible hematuria will have IgA nephropathy as one of the most important differential diagnosis. What did we study in respiratory system? We studied that IgA disease patient presents with hematuria only after 48 hours of infection. It is only after 48 hours of upper respiratory tract infection or urinary tract infection, patient develops a gross hematuria in IgA nephropathy. Whereas talking about the post-streptococcal glomerulonephritis, patient usually presents within 2 weeks with gross hematuria, hypertension, and minimal proteinuria that needs to be considered as a diagnosis of post-streptococcal glomerulonephritis. Remember, whenever you consider kidney tract symptoms, abdominal examination is an important examination findings. I understand most of the patients, most of us will only study the books and just go to the exam. But it is very important to learn abdominal examination when you are considering any abdominal question in USMLE Step 2 because they test clinical knowledge as well. For example, when you talk about nephrotic syndrome, patients will have proteinuria of more than 3 grams that is excreted in 24 hours. Whenever there is proteinuria, the most important protein lost is hypoalbuminemia. Whenever there is loss of albumin, it results in hypoalbuminemia. Whenever the albumin is lost, it decreases the hydrostatic pressure. Whenever it decreases the hydrostatic pressure, the water is moved towards the interstitial space and it causes leg edema. And how do you diagnose all these multitude of symptoms? It is only by the clinical examination that you can come to a diagnosis that this patient has got a syndrome. What is syndrome? Constellation of signs and symptoms is syndrome. It is by the abdominal examination you'll have to diagnose nephrotic syndrome. What is the confirmatory test for nephrotic syndrome? It is the kidney biopsy. And what are the indications for kidney biopsy? Pediatric patients who are not responding to steroids for more than 2 weeks is a potential candidate for renal biopsy or a kidney biopsy. Remember, patients with chronic kidney disease also do have symptoms. At the initial start of our lecture, we understood that the patient with chronic kidney disease usually have buildup of the waste materials that is manifested as uremia. Whenever the patient has uremia, the patient will develop nausea, loss of appetite, weight loss, and aversion towards the food. There will be loss of appetite as well. Remember what happens in chronic kidney disease. There will be loss of erythropoietin that happens. Whenever there is loss of erythropoietin, Whenever there is loss of erythropoietin, the anemia sets in. It is not only because of the loss of erythropoietin the patient develops anemia, but it is also because of the chronic disease that the anemia sets in. So, anemia of chronic disease is a sign of renal tract involvement or chronic kidney disease. When we talk about the symptoms of kidney disease and the urinary tract, I want you to understand the causes why the patient has got symptoms of renal disease. That is nothing but most of the renal diseases have got systemic factors. The first most important factor we discussed is diabetes mellitus. Remember, diabetes mellitus not only causes nephropathy and retinopathy, but it also affects the macrovascular strictures and cause coronary artery disease and also causes infarctions of the brain. So there is a high chance of possibility in diabetes mellitus patients where the chance of stroke is very high. In the neurology lectures, we discussed that lipohydinosis is one of the most important pathophysiological mechanisms that happens in lacunar stroke. Diabetes and hypertension, together with hyperlipidemia, affects the lenticulostriate artery and produces a lacunar stroke. Why am I saying this? Because diabetes mellitus not only affects macrovascular diseases, but not only cause macrovascular diseases, but also causes microvascular diseases. Remember, diabetes mellitus, when it causes nephropathy, the most important test not to be missed in the real life and in exam is diabetic retinopathy. Remember, whenever diabetic retinopathy sets in, it is the time the diabetic nephropathy sets in. Retinopathy and nephropathy goes together, goes in the same way. So, patients with retinopathy who were diagnosed to have diabetic retinopathy must be started on ACE inhibitors in order to halt the progression of diabetic nephropathy. That is why patients with diabetes mellitus and along with the history of hypertension, the most important medication is ACE inhibitors. Remember, patient with diabetes mellitus, the clinician loves ACE inhibitors because ACE inhibitors prevents retinopathy, ACE inhibitors prevents nephropathy, and ACE inhibitors also prevents remodeling of the heart and make sure that the heart failure is not progressed too much in short duration of the time. So one of the most important systemic disorder in renal medicine is diabetes mellitus. I also want you to understand there are some other important systemic disorders such as sickle cell anemia, sickle cell disease, which can cause papillary necrosis, tuberous sclerosis, which can cause rhabdomyolipomas in the kidneys. Cystinosis is one of the metabolic disorders which can cause cystine stones. Vasculitis, where the patient can present with different glomerulonephritis. Patient with SLE can also have renal involvement. Patient with hinox choline purpura can also have vasculitis and purpura. Patient with systemic sclerosis can present with renal problems or renal hypertension. Patient with Sjogren's syndrome can also present with immune-mediated vasculitis, which can affect the renal problems. Remember, 25% of the cardiac output goes to the kidneys. Why am I talking about cardiac output now? Because sepsis is one of the most important metabolic process or an infectious process where kidneys are easily affected. Remember, whenever there is a failing heart, whenever the heart doesn't pump adequate blood, there will be acute kidney injury. Whenever the acute kidney injury is seen in heart failure patient, it is considered to be a poor prognostic factor for renal disease patient and also heart failure patients. So sepsis is one of the most important cause of AKI. In the question, they will give you that the patient, say for example, 64-year-old male patient who has been diagnosed with diabetes since 12 years and is currently on glycoside. Now the patient developed a cough outside the hospital and was diagnosed to have a chest infection. The patient was started on so and so antibiotics, but the patient did not respond. Eventually, his blood pressure dropped and was admitted to ITU. What is the first most important thing you will have to consider whenever you treat the patient's acute kidney injury? You will have to correct the sepsis because sepsis is a state where vasodilation is seen. Remember, sepsis is also one of the conditions where high output cardiac failure is seen. But the contrast is high output cardiac failure with decreased systemic vascular resistance, that is, the vasodilation that is happening because of the nitrous oxide that is produced by the sepsis or the infective organisms decreases the blood supply to the kidneys. That is why acute kidney injury is a common presentation or common complication in sepsis. I also want you to understand that patient with hypercalcemia, think of renal disease. Patient with myeloma, think of CRAB criteria. Wherever there is CRAB criteria in USMLE Step 2 examination, it is the diagnosis of multiple myeloma until otherwise proved. What is CRAB criteria? Calcemia, renal failure or renal injury, anemia, and bone pain. The most common presentation of multiple myeloma is bone pain that happens to be in the night and worse at night and is not changing with analgesic use. It is also worsened with the movement as well. Remember, we discussed more about multiple myeloma in our hematology lectures, and we also discussed about differential diagnosis of back pain. I also want you to understand that you'll also have to remember pregnancy as one of the most important systemic problems with renal involvement. Why am I talking about pregnancy? Because preeclampsia is one of the most important cause where proteinuria can be seen in pregnant patients. Whenever there is proteinuria, think of pregnancy in a young patient. Whenever there is proteinuria, I also want you to understand that proteinuria is a pointer that is pointing towards preeclampsia, whereas proteinuria with epilepsy is eclampsia. Remember, the most important question asked in renal medicine is medications causing renal problems. Interstitial renal disease is what I want you to understand. Patients who are on NSAIDs, patients who are on chemotherapy, patients who are on aminoglycosides, they're all the risk factors for renal problems as well. Next, we talk about urine analysis. In the question, you will find urine analysis as one of the most common diagnoses that is mentioned. Remember, a dipstick test for catheter sample is difficult to interpret. This is what I want you to understand. Whenever you talk about proteinuria, it is the 24-hour proteinuria that is used. Very important. But in order to be accurate and in order to have the gold standard thing for proteinuria, it is the albumin creatinine ratio that we perform on a random sample. Normally, albumin creatinine ratio must be less than 2.5 in males and less than 3.5 in females. This is more sensitive than a 24-hour urine sample. Remember, ultra-sensitive dipsticks are available to test for microalbuminuria, but the examiner is not interested to test ultra-sensitive dipstick for examination. Next, we talk about hematuria. Whenever you think of hematuria, you will have to think of two causes, macroscopic and microscopic. Microscopic hematuria can be tested for dipstick, tested with dipstick. Whenever you see that the patient has got false positive hematuria, please think of myoglobin. Please think of rhabdomyolysis as one of the cause. And in the question, whenever there is rhabdomyolysis, patient will have history of trauma, overexercise, running, athlete, sprints, chemotherapy, malignancy. These are all the pointers that points out towards false positive hematuria. That is the myoglobin that you will have to test for. Next, we talk about urine microscopy. What are the most important things you will have to diagnose on urine microscopy? Remember, with the recent advancements, urine microscopy is very well underdiagnosed or used. But remember, whenever there are red blood cells, more than two red blood cells in the urine, it is considered abnormal. Whenever there are more than 10 white blood cells, it is considered abnormal. In the urine analysis, we find most of the casts in the USMLE exam. For example, whenever there are cylindrical casts, think of Tam horse false protein. Remember, the examiner would love to test about Tam horse fall protein, but in the options, whenever you find it is a normal finding in renal medicine, please go for normal finding. Tam horse fall protein is nothing but a collection of debris and renal tubular cells usually formed in the distal tubules. These are cylindrical in nature and it is important for step 1. Remember, hyaline casts are normally seen in patients who exercise and patient who has also got fever. Hyaline casts are also normally seen in the urine. But what am I most interested in? Red cell cast is seen in glomerulonephritis. White cell cast is seen in infections such as pyelonephritis and interstitial nephritis. In order to diagnose interstitial nephritis and white cell cast, I also will check eosinophilia and eosinophiluria. Interstitial nephritis, in the question, the examiner must mention that the patient has got rash. There is no answer without rash and eosinophilia that you will diagnose interstitial nephritis clinically. Please remember that. However, if there is no rash, but the examiner will give you eosinophiluria, you'll have to think of interstitial nephritis, please. Talking about the granular cast, I want you to remember that it is mostly from a degenerated tubular cell accumulation that we find a granular cast. But what is the final cast that is important? It is the broad cast that is seen in chronic kidney disease. Please remember in the question, you will be given that the patient's urine analysis shows that there is a broad cast. What do you think of? Think of chronic kidney disease. Next, we talk about urine microscopy for some of the renal calculi that I want you to remember. Patient with uric acid in their urine analysis. Think of stones and think of the most important thing, tumor lysis syndrome. But in tumor lysis syndrome, there will be hyperkalemia along with urine analysis showing uric acid. I also want you to understand patient with small bowel resection, there will be oxalate nephropathy, but in the urine, there will be calcium oxalate crystals that are commonly identified. Remember the most important question for USMLE Step 2, which shows that the urine shows calcium oxalate crystals. You will have to select ethylene glycol poisoning as one of the options. Whenever there is history of abdominal surgery and whenever there is history of urine calcium oxalate crystals, it is the oxalate nephropathy that you will have to diagnose. Remember, patients with cystine crystals in the urine analysis, think of cystinuria. Thank you very much. I'll see you in the next link and we'll talk about renal angiotensin aldosterone system and more about abdominal examination. Thank you very much.